I'd like to welcome everybody. Can everyone hear me? Can I get some thumbs up? Okay. I'm Jonathan Hall. I am broadcasting live from my bedroom. If you can see the back here, I'm just trying to stay out of everyone's way in my house. I guess those are sort of the COVID rules that we've been dealing with for a long time. Loosening up though. So nice to see everybody. Thank you for coming. Thank you for spending a beautiful evening, afternoon with us. Thanks to IRG for setting this up. I'm Jonathan Hall. I'm an orthopedic surgeon. I specialize in foot and ankle surgery. And I wanted to give you a rundown on the common orthopedic conditions of the foot and the ankle as I see it, as it comes to me in clinic every day, as I'm talking to people in the communities, things of that nature. I kind of put together a list of things that you will run across, you will see, you will experience. And of course, there are outliers. And if you have any questions, if you have any comments, things like that, please put it into the chat and we'll try to get to it at the end. I'm guessing about 40 minutes. I've done this talk a few times and that's about what it takes unless I get too long-winded. I promise I'll try not to on this nice day. Okay, here we go, getting started. That's pretty self-explanatory. The common conditions, here's the list here that we're going through here today. Sprains and fractures and arthritis of the ankle, shin splints, Achilles tendon injuries, injuries to other tendons such as the peroneals, plantar fasciitis, different fractures of the foot, flat foot in particular, arthritis, particularly the great toe is a separate topic here we'll talk about a bit. Bunions and hammertoes and neuromas. So the ankle sprain is very common. You've probably had one. Almost everyone you know has had one. And typically this is an inversion injury. So the foot twists inwards or supinates, as we say. And that tears the outside ankle ligaments primarily. If it's bad enough, it will tear the inside ankle ligaments as well, or if there's a different type of twisting mechanism. And the key findings are significant laxity of the ankle, swelling, tenderness, bruising, and oftentimes an inability to bear weight initially. And if it's bad enough and you end up with an x-ray, then those x-rays are essentially normal. And the one thing I do make note of is beware of the high ankle sprain. That's sort of a different player here. That's the typical sprain is the one that happens down low. The high ankle is the one that's above your ankle joint, if you will, between the tibia and the fibula bones. So the treatment here is rest, ice, compression, elevation, 72 hours, using a lace-up brace. If it's bad enough, you can get placed into a walking boot. Initial weight bearing with crutches and physical therapy if things are bad enough and you end up needing that help to recover. If it's severe, if it's recurrent, if it's not improving, that's where I come in. Come and see me and we can evaluate you. There are special things we do. Specifically, we do x-rays. We do stress x-rays to see if the ankle ligaments are holding up. That's where we take you into the x-ray booth and actually move the ankle around. Surgery typically isn't required. It's probably 5% of the time when people end up with surgery from an ankle sprain. Usually it's because there's an injury to the joint surface. There are injuries to the tendons that run along the ankle. There's multiple ankle sprains that leads to instability. There's a message here about not seeing the whole screen. I just want to make sure that somebody messages me and lets me know if there's an issue here with viewing the whole screen. Here's a little bit more about ankle instability. So that's if your ankle ends up becoming to a point where you sprain it all the time and you don't trust it. And that's oftentimes a really debilitating problem for people, particularly our athletes and folks who get out and exercise on a regular basis. Once the ankle becomes unstable, you just don't enjoy doing the things you typically used to enjoy. You don't trust the ankle. You have ongoing pain, and at that point, really, identifying the problem and talking about ways to fix it is the way to go here. So that's called ankle instability. That's after multiple sprains. So I think at this point, that's the conversation that I tend to have with my patients about a ligament reconstruction. And I find that it's a really good surgery. It's one that if your ankle is not holding up for you, then looking at different ways of fixing the ligaments so that you can trust the ankle again and you can get back to your activities. And I use what's called an internal brace system, which is a particular manufacturer that makes that. But essentially what it is anchors on either side of the outside ankle and a synthetic ligament. I then repair all of your own tissue ligaments around that and incorporate some extra tissue as well for the repair. And it works really well. We're essentially immobilizing people for about a month in splinting and casting, and then transitioning them to therapy and a walking boot. And by about 2 months, they can start getting back to all of their activities. Of course, it's a spectrum here, so there are people on either side of that. But I would plan for 2 to 3 months of recovery before return to sport. Moving on, ankle fracture is very common. It's one of the most common orthopedic injuries that we see. And the orthopedic surgeon's goal is to identify whether it's stable or not. So what happens is that you plant your foot and then your whole body twists around your foot, and it does that in either an internal rotation or an external rotation. Then depending on the position of your foot, whether it's flat on the ground or it's twisted, that tends to create specific types of injury patterns. And a stable ankle fracture is one that the talus, which is the bone, the bottom ankle bone, and the tibia, they actually still line up and they stay in alignment. If that doesn't happen, if the breaks are such that that bone underneath, the talus bone, is shifting and moving, that's called an unstable fracture. And that fracture is one that I need to fix with surgery. So that's typically identified when you really hurt your ankle badly, you've got bad swelling, bad pain, you can't walk on it, you end up at urgent care or the ER and they tell you your ankle is broken. That's where you come and see me and we have some conversations about if it's a stable injury or not and what type of surgery or not needs to be done to treat that. So this is just a bit more of the discussion. So here's a picture on the left side of an ankle fracture. That's the outside ankle bone called the fibula, or the lateral malleolus. That fractures, and so we put that back in place and bring that talus bone underneath the tibia again and hold it there, and then that heals. And so it's a recovery that ultimately takes at least 3 months to heal the bone and probably 6 months to deal with the soft tissues, the swelling and the discomfort and things of that nature before you're back to your activities. Moving on to arthritis. So arthritis in the ankle is actually not nearly as common. It's about 10 times less common than hips and knees. And that's primarily because we just don't see osteoarthritis of the ankle. The ankle typically gets arthritis from inflammatory arthritis like rheumatoid. And most significantly, most commonly, it's from trauma. So it's from breaking your ankle. It's from ankle instability, those things that we talked about before. So that tends to happen over time. You know that you've had an injury a long time ago. Your ankle's just gotten more stiff. It's swelling. It hurts to stand on it, to twist on it, those types of things. You get a lot of tenderness about it. And so at that point, after you've treated it with anti-inflammatories and physical therapy, you see your orthopedic surgeon, we talk it through and decide some options for you. Sometimes injection therapies work, sometimes bracing works. You guys might be curious about different types of injections like stem cells and PRP. Well, there are very few data to support that use. However, I do it occasionally for folks if they're just trying desperately to get back to an acceptable quality of life and functional level and desperately trying to avoid surgery. So, you know, it's an option, but corticosteroid injections are just as useful, honestly. And I also do hyaluronic acid injections, which are like the gel injections that you guys may have heard about with hips and knees, et cetera, particularly knees. So once the arthritis is bad enough, now we really try to identify arthritis, and arthritis, remember, comes in multiple different forms. So a bone spur is arthritis, right? A joint surface lesion called an osteochondral lesion, that's arthritis. Okay, so when people discuss arthritis, there's this whole spectrum of things about that. And so what arthritis can be, it can be something that we can deal with a joint sparing surgery, where we're going in arthroscopically, dealing with a joint surface problem by microfracture, or using your own cartilage and implanting it, or using an off-the-shelf cartilage product. I mean, these are different things that I do for folks, and it works really well. But once that whole joint surface wears out, then those treatments aren't helpful anymore. We can't take out a loose body. We can't take your bone spurs off. You know, things that are very minimally invasive with an arthroscopic procedure. We then have to start moving forward with other options, and those types of options are fusion procedures, are ankle replacements, and those are the typical ones. Sometimes I'll change the alignment of your ankle if there's some type of a deformity that we can correct to offload it and move things around a little bit. But that's a more advanced conversation that we can have if heaven forbid you're at that point. So medial tibial stress syndrome, or AKA shin splints, that's a very common thing for runners, and all of our physical therapist friends see this regularly. So I thought it was important to talk about this in particular. What it is it's a condition of overuse typically. It's a condition of mechanics that run awry. It's a condition of not changing out your shoes to having shoes that aren't quite as cushioned. Hard surfaces versus a more cushioned surface. All of these things can cause this inflammatory condition around the bone. Now, it's not the bone, it's actually an elevation of the periosteum, which is the bone skin, if you will. And so this elevates off, this inflammatory condition happens. And so people end up having a lot of pain with just trying to run and to do any sort of higher impact activities typically. And it's very point tender or area specific around the front of the shin. So it's treated with rest, ice, compression, elevation, the typical stuff, improving your flexibility to work on any tightness of your musculature, changing out your shoe wear, looking at different orthotics options, working with your physical therapist to address gait mechanics, to see if there's something that you're doing that's placing additional stress with what's called the ground reactive force. So essentially you put your foot down on the ground, and the forces that come up through your body, what is your body doing to alleviate those forces? Is it all going right through your tibia because you have stiffness in other areas, et cetera? So if this isn't getting better, then you really do need to get checked out. And another thing that I mentioned here is you need to be pain-free for about 2 weeks before you go back to your sport. Otherwise, it's probably going to come back. But if you're not getting better, you need to get an x-ray. And the reason for that is there are two conditions that can happen. The first is a tibial stress fracture, and that can happen. And it's a real bad player. It's one that often ends in surgery with a big rod that we put up your tibia to get that to heal. And the other one is compartment syndrome, and it's what's called, and I'll talk about this next, it's called exertional compartment syndrome. So those are the potential problems that can come into play. And so shin splints are one thing. If it's getting worse, please come get checked out. Exertional compartment syndrome is where there's an injury to the tissues of the leg bone. So when I say leg, the thigh is up above your knee, the leg is below your knee. And so the conditions happen in the leg. And there are different compartments there surrounded and encased in this stuff called fascia, which is like this canvas material that houses the muscles. It's what gives us our muscle definition. Otherwise, we'd be a blob like Jabba the Hutt, right? So it gives us this definition. But what happens is that tight canvas material, if there's an injury or swelling or overuse, something that happens on the inside of that compartment and it swells up, then the pressure goes up in that compartment. There are 4 compartments in the leg. And each of those can independently get too swollen. And the issue there is that you have blood vessels that go through those compartments. You have nerves that go through those compartments. And if you're if you're getting too much swelling, then you can actually pinch off the veins. The arteries are pretty hardy, so they keep pumping blood in, which makes the problem worse, right? But the veins, which drain the compartment, they're pretty flimsy. And so then you're not draining the compartment, it's getting worse. The nerves then are very sensitive to blood supply. And so that unfortunately can lead to what's called compartment syndrome, which can kill the muscle tissue, kill the nerve tissue. And it's a relative emergency. But in a runner's situation, it's exertional compartment syndrome, where you just start to get more active and the swelling goes up. And then if you just rest, then you'll actually see the pain and those symptoms go away. So what we see with folks with exertional compartment syndrome is that it's not like this terrible thing where you're losing your nerves or your muscles. It's more this situation where you just can't stay active, where you get out and you try to run and it just hurts and you have to stop. So sometimes if those problems are diagnosed, and you'll see this needle here on the screen, then that's actually how we measure the compartments. And so we measure the pressure there. So it sounds kind of mean and rude, but it is the way that we have to do it to get that pressure measurement. And then at that point, we can decide if it's too high, then we can do a surgery where fairly minimally invasively, I can go and I can release that fascia tissue, that canvas-like material. The Achilles is a major player. It's the biggest tendon in our body, and it is the one that when it goes bad, it just changes your life. Tendinitis is where you're out and you're doing too much, and it starts to get inflamed, and you get that nodule on your Achilles, and it's hard to get rid of, but it's the tissue around the Achilles where that happens. Tendinosis is the degenerative process of the Achilles, so that's over many years. You get these big bone spurs on the back of your heel and things like that. So those are the two different things. They're treated somewhat differently, although we do immobilize people in a walking boot if it's bad enough, both situations, and then go from there. But essentially, once you start having those symptoms, it's a good idea to get treatment, get identified, see your orthopedic surgeon, see your physical therapist, get identified with where the problem is. Is it coming from your Achilles or not? I always take x-rays because we can identify if the bone spurs, if they're bad or not, how long has this condition been going on? Is there something else going on? Do you have a stress fracture of your heel, et cetera? Are there other tendons that are injured? And so ultimately, imaging with X-ray and then MRI potentially if the question still is posed about what the problem actually stems from. Treatments are heel lifts. So if you take some pressure off the Achilles, oftentimes, especially with our runners, you have really tight calves and tight Achilles, and so it's hard to get loose. And so if we raise up your heel, then that actually takes some of the pressure off of the Achilles while you're healing. Along with stretching and going from there. The typical, RICE treatments and NSAIDs. When you have a precursor, like when your Achilles keeps bothering you, like a tendinitis, you are at risk for an increased rupture risk. If it's more tendinosis where you have bone spurs, then your rupture risk really isn't very high. I find that with Achilles, the tendinitis is treated well with PRP. There are some new studies to show that a high volume, low dose corticosteroid right in front or between the Achilles and the back of the ankle actually is quite useful. We typically don't inject corticosteroid into the Achilles, but that's one of the most recent studies which had some pretty good results that were equivocal to PRP and didn't have the rupture risk. So some new stuff coming out. So if these things aren't getting better and you just keep getting worse, and oftentimes, like I said, we immobilize you. The tendinitis can be treated, if all that stuff fails, could be treated with a debridement surgery, usually releasing your gastroc muscle, which is higher up in part of the Achilles, loosens things up just a little bit, and that helps as well. And then the Achilles, the degenerative problems with the Achilles, that stuff is treated very well with a reconstruction surgery. But that's only, of course, after you've been dealing with this thing for a long time and you just can't get back to the quality of life you'd like. This is a rupture. So I talked about precursor symptoms. Oftentimes people do report that they've had some tightness or some stiffness, when they get up in the morning, aching and pain in their Achilles when they're trying to stay active. But Achilles rupture is sort of the weekend warrior type injury, where folks are not as active as they once were, and then they get out and try to do exercises and activities that are pretty taxing, and ultimately the Achilles ruptures. It's an eccentric contraction. Okay, so that means that it's slowly lengthening when it's loaded. So that's typically when the Achilles pops. I always think about one of my family friends way back when he was pushing his car up a hill. Probably needed a little more help, I would assume. But when he did that, he ruptured his Achilles as he was pushing his car and extending his Achilles. And that's pretty classic. So oftentimes people describe that they've been shot. They feel like they just had somebody, they look back and did somebody kick me, right? And they feel a pop, even an audible pop happens. If those things happen to my physical therapist friends, as well as everyone else, if that happens, then it's important to be evaluated very quickly and put yourself into a boot, a splint, something like that plantar flexes, points your toe down, because that gives you every option after that. There are both surgical and non-surgical treatments for the Achilles, and it really is patient dependent. So for my young athletes who rupture their Achilles, who are quite active, I usually recommend surgery for them. And that typically is because it's a quicker recovery. There are still data to show that the re-rupture rate's a little bit better, and the explosive power is better. So, but with that said, non-surgical treatment is a good treatment. We treat people with the functional rehabilitation protocol, which is essentially a hinged boot that allows people to start moving, but it limits your motion. So it points your toe down and it allows you to just slowly start doing that. And then in a couple of weeks, we just change the angles. And so you can bring your foot up and then go down like that. And then a couple of weeks later, we change the angle. And so that allows the Achilles to scar in at the appropriate length. But if you come to see me a week later and you've just been walking on, or you've been in a regular boot and your ankle isn't plantar flexed, then we really have to fix it with surgery, because the length is too long. So you're functionally too long. So you won't have the power that you need to push off. So the last thing to talk about here is that the recovery is quite long and prolonged with Achilles tendons. That's for the reconstructions, the ruptures. It's just a big tendon. It shrinks down your calf muscle. It heals itself in 10 to 12 weeks, but then you just have all this recovery to get your strength and your muscle bulk back. Peroneal tendons are the ones on the outside of your ankle down into your hind foot. They are the ones that evert or push your foot outwards. They typically come in with ankle instability. They go sort of hand in hand. People have an inversion injury. They try to catch their foot. Maybe they have an unstable ankle and their foot always turns, and now they're trying to catch their foot all the time as it tries to tip into supination. And that essentially leads to the peroneal tendons being overworked and ultimately tearing. And they tear in not in just a pop fashion like this. It's kind of a mop. And so they split, they get wide, they get ugly and inflamed, and they end up being non-functional after a while. We immobilize people initially for 6 weeks. We do this for a lot of these tendon type injuries to see if they can get better. We treat them with NSAIDs and rice and consider some other injectable options. If those things don't work, then I usually image this with an MRI and give people some options about treatment. Primary repair of these is pretty much 30 or younger, 30s or younger. But what I can do is there are some studies to show that all you need is about 1/3 of your tendon. So if you have about 1/3 of the tendon that's still functional, usually we can just clean it up and that's good enough. And then you maintain both of those tendons. There's the longest and the brevis that run next to each other. You can see in this picture up here in the corner. And those actually function in synchrony. So you're firing them both at the same time. They just go to different places. And so if the tendon injury is bad enough, usually on the brevis as it turns around the outside of the ankle bone, I can actually stitch those tendons together above and below and remove the damaged portion. Plantar fasciitis is a diagnosis you really don't want. I don't want it. Raise your hand if you do, but I don't want it. It's one of these that unfortunately is a bad player. It debilitates people. It hurts. It doesn't have good surgical outcomes. We do a whole protocol for people when they come and see us, and we really try to focus, and I know our therapist friends do the same thing. We really try to focus on their mechanics. We try to focus on their shoe wear, making sure that they're protecting themselves and immobilizing themselves appropriately, getting off of their feet, stopping their activities for a good 6 weeks. You'll hear me say 6 weeks a lot. That's really just because 6 weeks is what it takes for the soft tissues to heal appropriately. So we kind of do 6-week intervals here. Ultimately, with plantar fasciitis, the injection therapies aren't the solutions. There are some studies to show that PRP is helpful, so certainly an option. I find that the bone spur itself really isn't a pain generator. It's just a representation of the condition. So if we can stretch your calf muscle out, there's some pretty good studies to show that helps. Then that's the way to go. Start that first. Pad the heel, ice it down, anti-inflammatories, avoid being barefoot on hard surfaces and pounding on it. And then consider the injection therapies. The surgeries are inconsistent. The results, I'm not a big fan of the surgery. I do it occasionally for folks who are just so frustrated and they've been dealing with this pain for years and it's just debilitating and changing their life. So I do everything I can to help. I really want you better, but I don't want to hurt you, right? And so we do this in a way that is safe. We do this in a way where we communicate with you and let you know that you're at a point where the problem is so bad that you need something done, and we do our best for you. So with that said, I think the results are probably 50-50. I think people still have pain to some degree in some areas. Sometimes what we do when we release the fascia and take the spur out and loosen up the calf muscle is the pain is then transferred to another portion of the foot. The plantar fascia is this, once again, canvas-like tissue that goes from the heel to the base of the toes, and it helps to distribute your weight. So if we're releasing the fascia, it's not like your foot goes flat, but it just alters, even microscopically or subtly, it alters the way that you stand. And our bodies are very sensitive to that. So it can sometimes hurt you pretty badly by altering the weight to another portion of your foot. So with that said, plantar fasciitis, nobody's friend, but we'll conquer it together if it happens to you. Stress fractures are something that's quite common. It happens in runners quite a bit. The metatarsals are really common to get a stress fracture. Usually it's because of the tightness of your calf muscle, running surfaces, things of that nature where you just have, like I talked about, that ground reactive force. So your foot hits the ground, this shock wave of force goes up through your foot. Well, if your calf muscle is tight, then your foot tends to hit the ground, with the metatarsals being more affected at a higher rate during your gait cycle. I talk about this with folks in clinic where I kind of show them, if your calf muscle is tight, your heel hits the ground with heel strike. As you're rotating in your swing phase with your other leg, as you're rotating and your forefoot hits the ground, if your calf is tight, your forefoot hits the ground sooner. And so that ends up putting stress across the metatarsals because the ball of your foot is the head of the metatarsal. So it puts more pressure across your metatarsals sooner in the gait cycle. And that then, if you're running for miles, is thousands and thousands of steps, right? So it just is this micro trauma that builds up. So definitely get an x-ray if this is, particularly if you're swollen across the top of your foot. I think it's important. Immobilizing you in a walking boot, usually getting you on crutches, offloading the foot is important. The x-rays will probably show some type of a fracture, meaning a small, just black line, minimal displacement. Sometimes people displace before they even see me. If it's tried to heal, you'll get some early callus formation. But once you get enough healing and your pain starts to go away, you need to really focus on your calf muscles in particular and your shoe wear. Surgery is not typical in this unless it displaces or there are multiple metatarsals. So when people start dealing with 3 and 4 metatarsals, then we start talking about surgery if there's any displacement, just to try to get the bones to heal and get your mechanics back normal as soon as possible. The Lisfranc joint is the midfoot joint. That's your arch joint, right? So if you think about Lisfranc, the name, it comes from Napoleon, one of Napoleon's surgeons. And that's where they did the amputations way back when, and that's where they named the joint. But don't worry, we're not going to be amputating across the Lisfranc joint for anybody with these types of injuries. The Lisfranc joint is the keystone in your arch, essentially. So longitudinally as well as transversely, the arch has this sort of keystone at the second metatarsal, and the Lisfranc ligament goes from that base of the second metatarsal to the inside cuneiform bone, which is one of the middle arch bones. And when your foot is loaded, your toes are loaded, and then someone falls on your heel, that's a classic one. You can kind of see one of these football players getting rolled up there, and the tackler is falling right on his heel, and that causes that Lisfranc injury. So that actually breaks your arch. So when someone says they have a Lisfranc injury, their arch is broken. And when that displaces, and you can see the X-ray here, the one without the hardware, there's a subtle shift in what's called a flex sign in between the first and second metatarsals. And the shift of the second metatarsal laterally is what identifies this injury. So essentially your foot just folds up. And so this requires surgery. We have to get your arch back lined up. So I line it all back up, and I typically use a plate and screws. This is a picture I got online, which shows the fixation, but I typically use a plate over the top. And I'll use a ligament reconstruction called a tightrope that goes across there as well. And that preserves the joints in a better fashion. So I see this all the time. I think people do well. Unfortunately, they have a long recovery, but ultimately they get back to sport. It's just it's a bad player. So we have to identify it. We can't miss it. Fifth metatarsal fracture, people use the word Jones fracture as synonymous to a fifth metatarsal fracture. There are actually multiple different types of metatarsal fractures. The Jones fracture is the one named because of its poor ability to heal on its own. It's about a 30 to 40% non-union rate, and that's just because where it resides on the bone. This X-ray is a true Jones fracture, and that's where the shaft of the bone and the metaphysis, which is the more flared out proximal portion, come together. And the blood supply to the bone there, it comes from the middle of the shaft and the base of the bone. And so it kind of peters out right there. So the blood supply isn't quite as good in that region. If it's a more proximal, meaning more close to the ankle and the heel injury, then that's an avulsion fracture. And we usually can treat those without surgery. About 95% of the time that heals. If it's farther down, it's a spiral fracture, a dancer fracture, and that one can usually heal unless it's displaced significantly, and then that requires surgery as well. So the fifth metatarsal fracture, or the Jones fracture in particular, is one that typically requires surgery, especially for our young athletes. We usually put an intramedullary screw, so a screw down the center of the shaft of that little bone, for folks to get them back to sport sooner. Otherwise, if you can hold off and we can immobilize you in a cast, be non-weight bearing for 6 weeks, we can try that. But that's just a conversation that we have with each individual patient. Here's the surgery. It's a percutaneous surgery. What I do is I essentially use an X-ray to identify the starting point, and I put a guide wire down across the inside of the hollow bone, and ream over that, so drill it out, and then place the screw. The screw is partially threaded, so it compresses across the fracture with the threads versus the head of the screw. You're in a cast for about 6 weeks, and non-weight bearing, really important. And then once we start to see some signs of healing, we get you back playing again. I've done these with athletes, get them back to sport really quickly in relation to what it takes to heal the bone. So, we see people getting back to sport 8 to 12 weeks, but we really have to be cautious if it's sooner than that. Flatfoot is a condition that happens over time. When we say progressive, that's something where folks are noticing that their arch is falling. Most of the time, that's something that happens with folks who are later on in life, middle age, and obesity is a problem as well. But it's not the only issue. The issue is just genetics of the tendon. Unfortunately, what I tell folks is that your mom and dad gave you a bunch of awesome stuff, and in this situation, if you're dealing with this is not one of them. It's something that is a problem for folks. You lose the ability to push off, so you can't get your heel off the ground during gait, and so you end up turning your foot outwards and walking sort of through your heel with an external rotated foot, and you get swelling and pain across the inside of your hind foot and your ankle, if this is the case, when I first thing I do is look to see if you're symmetric. If you're not, then we have a serious conversation about what we need to do about this, because you're really looking at surgery if that's the issue. If it's just an inflammation, if you have a tendinitis going on and your foot is flat but relatively symmetric to the other one, we can immobilize you in a walking boot for 6 weeks, and there are special posterior tibial braces we can try as well, arch supports, orthotics. Those are things that tend to work, but it's a condition that unfortunately tends to worsen over time. And so a surgery that I do quite frequently is flat foot reconstruction. And so that's where we actually recreate your arch for you. And that can be done in multiple ways. And that's a conversation that, hopefully we don't have to have, but if you're having that problem, please come talk to me. We can give you some options and some ideas, and at least paint the picture for you and help you to get through it. Hallux rigidus is a fancy word for arthritis of the big toe. Very common, one of the most common arthritic conditions of the foot. So when we talk about arthritis in the ankle, remember that really osteoarthritis isn't common. Arthritis in general in the ankle isn't common. Well, the common areas of arthritis are in the midfoot and the forefoot. The second tarsometatarsal joint is the middle of the foot next to that Lisfranc joint. That one goes bad for a lot of people early. And the base of the big toe joint is the player here that we're talking about. You get big bone spurs and stiffness. It alters your gait. You're shifting your weight to the outside of your foot, causing problems, even stress fractures in other places, leading to pain in your knees and your hips and your back. So the first thing that we do once we identify that is we try to change your shoes. We say, well, what are you wearing? Can we stiffen up your shoe? Can we get you into a rocker bottom shoe? Something that we can put into your shoe, get you a carbon fiber foot plate, or find something that stiffens your toe box of your shoe and keeps your big toe from having to move. Once we can do that, then hopefully you can get along with your life. If that doesn't do it for you, then essentially at that point, we're talking about surgery. And that's one of two things. So either we can clean it up, one of three things. We can clean it up, take the bone spurs out, clean up the joint, smooth it out. I contour the joint so that it moves really nicely, but arthritis is still there. So if it's not to the most extreme of the conditions of that arthritis, then we can still get it moving. If it's very extreme, like what you see on the left-hand side here, a normal is in that red box, and then the very extreme, the bone-on-bone arthritis is right next to it. If that's very extreme, then we're just talking about fusing that joint. You're not moving it there. It's just causing you pain. So we're going to trick that bone into making it one bone, and that'll work really well for folks. I put it in a position where the toe is up just a little bit. Nobody knows but you, but it's up just a little bit so that you can still walk fairly normally, get into low heel shoes, things like that. The only other option for folks is between those two procedures. I do a half joint replacement, and that's one called a Cartiva, and it's got some reasonable data behind it. I've done a few of them, and the patients seem to do fairly well. So it's an option. It doesn't burn any bridges, where if you did need to have a fusion later, that could happen. it saves you some of that motion that you lose with the fusion. But once again, I think fusion is really gold standard. It's a good procedure. There are studies to show that people are getting back to actually fairly reasonable athletic endeavors. But make no mistake, you're not back to normal, right? So surgeons make you different, right? God made you normal, and surgeons just make you a bit different. We try to put you back together in a way that gets you back to all your activities. And it's a good surgery, but sometimes we have to have that conversation about, well, what are your goals, right? What do you want to get back to, and realistically, what can you get back to? So. Bunions are essentially widening of the forefoot, and the metatarsals, those middle bones in the foot, they get wide. The first metatarsal gets quite wide, and you end up having pain in your bunion. Oftentimes, shoe wear becomes really hard, and you get swelling along that inside bunion area. If it goes on, the natural history of it is you end up crossing your second toe over the big toe, or it hammers back behind the big toe. The big toe goes over the top of it. It can lead to problems in the second toe joint and further along. So we focus on, when I see folks with this, we just focus on, well, what are you doing with your shoes? What are you doing with your activities? What can we do with padding and bracing and things of that nature? We can't stretch it back. It's a natural progression. It doesn't stretch. It's just the bony architecture changes. But we make sure that we put you in the optimal situation, environment, to get you pain-free and back to your life. If that doesn't work, then surgery to correct the problem. And I put a couple of surgeries up here. I do two of them. One is a scarf osteotomy, which is the one on the left-hand side where you see the bone shifting. So you can see, I don't know if you see my pointer here, but my cursor is right over where the bone cut would be. Basically turn the first metatarsal into two pieces and then shift the piece down by the big toe over towards the lesser toes, and then put screws across it. The other one that's more powerful for folks with bigger deformity is the Lapidus procedure. And it's a good procedure. We're fusing one of your midfoot joints, the first tarsal metatarsal joint. So the base of the first metatarsal and the medial cuneiform get fused together, and it allows me to change the rotation of the bone, which tends to pronate over time. It allows me to change the angle and give you a little more of an arch. Sometimes folks, we get this instability there where your foot goes flat, your bunion gets big. So it helps me to deal with a lot of deformity. It's a good one. So we talk about those things. If at some point you get there, it's about a 6-month recovery. We do these outpatient, and folks are quite pleased once all is said and done. I know there are some horror stories about bunions, but I certainly am not seeing that in my practice. I think people are doing quite well. We just talk them through it, and we try to communicate as best we can about what they'll experience, how to prepare for it, just like every other surgery, how to stay ahead of the pain and deal with it, and just make sure that the process is clear and concise, and the communication is good, and then we're following you regularly to get you through it. Hammertoes are painful curling of the toes and deformities of the lesser toes, and oftentimes it's in conjunction with the bunion. So the big toe is a bully and pushes the second toe out of the way, and it gets stiff and painful. And so correcting the hammertoes are oftentimes done. There are a lot of intricacies across the forefoot. I mean, the neuromas are in between typically the second web space and the third web space. The joints themselves can go bad and become unstable with plantar plate injuries. The hammertoes can lead to dislocations of those joints. So certainly get that checked out and evaluated. And if it's flexible, we can do some things to try to stretch it out and give you accommodating shoe wear, and make sure that we can do our best to control your discomfort. But ultimately, if that doesn't work, then those can be straightened out with a surgery. And this, I think this is the last one here, folks. We're almost done here. The neuromas are essentially pinched nerves. So they're the digital nerves that run from the tibial nerve coming down the inside of your ankle and then spreading out in your plantar foot. And then they go through the metatarsal spaces, the intermetatarsal spaces. And the most common ones are the ones between the third and fourth and the ones between the second and third metatarsal heads. So if you're having burning pain, if you're getting numbness in your toes, if tighter shoe wear is uncomfortable, get checked out and we'll take a look at that. Oftentimes with a simple physical examination, I can identify these and treat them with a corticosteroid injection to see if we can get it to settle down, alter your shoe wear, pad your shoes appropriately. If that doesn't work, then the neuroma can be literally removed. We literally cut it out. It's inflammation all around the nerve. You can't save the nerve, but it's not a motor nerve. It's a sensory nerve to the web space. So people typically don't mind. They'll readily exchange a very painful condition for some numbness in the web space. That's a pretty quick recovery as well. So thank you very much. This is Fun Co-op in Everett. These are my kids, and appreciate everybody taking the time on such a beautiful day to spend with me. All the best to you. Feel free to come by and visit me anytime. I'm at ProOrtho, ProLine Surgeons in Kirkland.